Good morning. I'm Bob Kramer, and we have a very special guest to begin today's conference sessions. Welcome to our day 2. Medicare has a goal to have 100% of Medicare beneficiaries in value-based care arrangements by 2030. Dr. Meena Seshamani, Director of the Center for Medicare and Deputy Administrator of CMS, is going to have a fireside conversation with David Grabowski, professor at Harvard Medical School, and share her thoughts on the direction that the Medicare program is heading and the implications for the senior housing and care sector. Dr. Seshamani accepted NIC's invitation and traveled to Dallas to speak to, but also listen to and learn from the senior housing and care sector, from providers of senior housing and care, and from their healthcare partners, plans, payers, and to understand the new partnerships that are being formed by many of you in order to address the complete health needs of your residents and drive better health outcomes. Last night, a group of us had a wonderful opportunity to interact with Dr. Seshamani in a candid and free-flowing discussion, and I know we'll be continuing that this morning with David Grabowski and Dr. Seshamani. Before turning the program over to David and to Dr. Seshamani, I'd like to introduce and thank our sponsors for today's session. SAGE. SAGE is a next-gen operations management system that elevates the senior living experience. I'd like to welcome to the stage Raj Mehra, CEO and co-founder, and Lindsay Darty, head of community. Raj, Lindsay, thank you so much. Please.
Thank you. Thank you, Bob. We at SAGE couldn't be more aligned with Nick's focus on providing insights into action. The SAGE software revolutionizes the nurse call process with an operations management system that all the while that we collect data with, that we help our users leverage to improve care, revenue, and the experience for residents and caregivers.
My grandmother was a caregiver and my mother was a nurse. I started in senior living at 18 years old. What I noticed through the years of becoming a caregiver to a nurse is all of the paper. If you know, you know. Paper to track, log, and communicate. It really didn't help me as an operator. So we deployed SAGE. SAGE gave us the data insights that we needed to make actionable improvements with staffing levels, LOC variances, and just overall operations. SAGE had such an impact on me that I joined SAGE. I wanted to lead senior living in a bigger way.
SAGE isn't just a new technology, it's a promise of increased net operating income and improved community culture. Our communities see a 53% reduction in incident response time, a 30% improvement in caregiver retention, and an additional $250 of net operating income per resident per month. Some of you in this room have experienced the power of SAGE already. Some of you will join them. Together, let's drive thought leadership, advances through action in senior living operations together. Thank you.
Thank you.
Thank you. Thanks very much, and thank you to SAGE again. Now, in introducing a little more fully our participants in our fireside conversation, again, we're thrilled to have Dr. Seshamani with us. She's a Hopkins-trained surgeon, ENT surgeon. She's an Oxford-trained PhD economist. She leads, as I said, the Center for Medicare at the Center for Medicare and Medicaid Services, where she's responsible for the operations and policy for the healthcare coverage of 63 million Americans in the Medicare program. And of course, that number we know is growing by 11,000 every single day, for instance, this year. Previously, she was on the senior executive leadership team for the MedStar Health System, a 10-hospital, 300-plus outpatient site system. And during the Obama administration, she led the Office of Health Reform for both terms during the Obama administration, therefore playing an instrumental role with regard to regulations and implementation of the Affordable Care Act. Joining Dr. Seshamani will be David Grabowski, PhD, who's a professor of healthcare policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. He's a member of the National Academy of Medicine, has published over 240 peer-reviewed articles in leading journals and publications. Of particular note to all of us connected with NIC is that David, along with Caroline Pearson, was one of the lead authors of the seminal 2019 Health Affairs article, The Forgotten Middle, which really launched a spotlight, not just for NIC, but nationwide, on the issue of those stuck between having too much in resources to qualify for long-term care or housing assistance from the government, but not enough to afford private pay senior living, at least for very long. David has also served up until just recently, from 2017 to 2023, as a member of the Medicare Payment Advisory Commission, or MedPAC, an independent agency established to advise Congress on issues affecting the Medicare program. During the pandemic, he served on the CMS Nursing Home Coronavirus Commission. He's also a member of the National Academy of Sciences, Engineering, and Medicine Committee on the Quality of Care in Nursing Homes. So we have two esteemed leaders in the area of healthcare, long-term care, and post-acute care. And I'm thrilled now to turn over this conversation to David Grabowski. David, thank you.
Great. Thank you so much, Bob. Good morning, everyone. It's great to be here with you. The only thing we had asked Bob is that we actually have a real fire on stage, Bob, for a fireside chat. You didn't come through, but otherwise couldn't think of a better environment. So I'm super excited to get to talk to Dr. Seshamani today about a series of issues regarding the Medicare program and how they impact senior housing and skilled nursing. So let's dive right in, and I'm gonna ask a kind of a broad kickoff question here. Medicare is very complicated. The Centers for Medicare and Medicaid Services is very complicated. You're the head of Medicare at CMS. Tell us a little bit about your role and where that sits in the broader framework of CMS.
Sure, and it's really wonderful to be here with all of you today, so thank you for the opportunity. So as Bob had mentioned, I lead the Center for Medicare. So within the Centers for Medicare and Medicaid Services, there are various centers. So there's the Center for Medicare, the Center for Medicaid and CHIP Services, the Center for Consumer Information and Insurance Oversight, which oversees the Affordable Care Act marketplaces, the Center for Program Integrity, and the Center for Clinical Standards and Quality. The Center for Medicare is the hub for the policy and operations for the Medicare program, which is now at 65 million people. And we have an incredible team. I think that is honestly one of the things that has been most amazing for me, is being able to work with a group of incredibly mission-driven, smart people who understand the program and really want to serve the 65 million people who rely on our program. And I think, you know, Bob had also mentioned some of my background. I am coming from having practiced medicine and seen patients up until I took this role. In fact, I had one senior who told me that she was going to call President Biden and tell President Biden that he couldn't have me because she wanted me to keep seeing her as a patient. I also led care transformation for a major health system, and under that portfolio included service lines like community health, geriatrics, palliative care, case management, all of our care management programs with primary care, and all of our disease management pathways. So I also bring the stories of my patients and of the populations that we served through our various programs to the work that we're doing now in the Medicare program, which ties into, as Bob mentioned, our goal to really have everybody in the Medicare program be in a more holistic care model where they are taken care of as people rather than treated as a specific ICD-10 code. And I think that is where there is huge opportunity for all of us to be working together to make sure that we are delivering on that goal.
Great. Your role sounds incredibly busy and engaging. That's probably the understatement of the day so far. You get asked a lot to speak to different groups around the country. Why this group? Why senior housing, skilled nursing, capital partners? I don't know, and Bob can correct me, I don't know that we've ever had somebody from CMS at this meeting. This is a first. Why did you feel this was a priority to speak to this audience?
Yeah, well, a few things. Number one, coming from where I was, right? I was on the front line taking care of patients. I helped lead the COVID response for our area, the DC, Maryland area. And COVID really presented this incredible disruption that also was an opportunity to rethink how we provide care and how important it is that we consider everything that impacts someone's health, because most of it doesn't occur within the four walls of an office visit. And so with that, being able to really have a call to action and engage everybody who is involved in impacting the health of the people who rely on our program is really front and center. So being able to meet with all of you. Also, I've been having conversations with small businesses, with innovators, as well as healthcare providers, patient groups, health plans, some of the more, traditional, if you will, interested parties to engage with, because we all have to partner together to figure out how we can provide better care, improve the health of our populations, and be able to spend the healthcare dollar in a more effective way. So as Bob mentioned, we had a conversation, last night, and really I want to drive everyone to a call to action where we know that if you can keep people healthy, prevent illness, keep them healthy, think about them as whole people where their mental health and behavioral health ties into their physical health, that is a win-win. And we need to have data around that. We need to understand what is being tried, how is it working, because then we can take that in our program to be able to say, okay, how can we, within the authorities that we have in the Medicare program, try to leverage that so that we can make sure that this program is working the best that it can for the people that it serves.
I love the terms you used, holistic and whole person. I know that value-based care has been a major emphasis of the Biden administration. How do we engage Medicare recipients in those value-based care arrangements?
That's a great question, because I'm sure if I go walk down the street after this and say to someone walking down the street, what do you think about that value-based care arrangement? We all know what answer we would get, right?
Right.
We actually have a concerted effort to explain to people what the promise is of having a different way that you are cared for. I think we can all agree that people generally have frustrations, that they feel that nobody knows everything that's going on for them, that the healthcare system can be very complex and difficult to navigate. And those are some of the things that really are the promise of these kinds of models, where you have healthcare providers working together to be able to provide better care. Where, for example, now for the first time, Medicare is paying for community health services, because we know that food and housing, transportation all impact someone's health, and where you can pay a healthcare provider to screen for health-related social needs and then pay to be able to address those needs, paying for care navigation, paying for caregiver training, right? These are all things that we know can really make a difference in the lives of people, and I say people, not just patients.
Right.
And so being able to really move in that direction, we need to explain this in understandable language for people, and not everybody, I can't reach everyone myself, and not everybody would want to listen to me. They want to listen to trusted partners in their community. And that's why we need to engage everybody in being able to both get ideas from all of you of where there are opportunities that Medicare can put its shoulder to the wheel to really improve care, and then when we put out something in a 2,000-page regulation, we know not everybody is, manning the Federal Register every day. We need to engage all of you to make sure that what we are collectively trying to do comes to life on the ground, where we are then implementing together. We are explaining to people, hey, this is an opportunity to be cared for in a different and better way. Do you want in? What can we do to make things better? And being able to work with healthcare providers, across the spectrum. So I really think it is that two-way street that you touched on that's so important.
We're going to assign everybody 200 pages from the Federal Register. So that'll be your homework from this. No, I wouldn't do that to anyone. That's dense reading, to say the least. I wanted to follow up, though, on this idea of value-based care. We talked about it from the perspective of the person. I like that, not the patient, the person. Can we also think about it in the ways that maybe it touches a lot of the folks in this room? When we think about value-based payment, it's often Medicare Advantage plans, sometimes it's special needs plans, it's accountable care organizations. Can you talk about some of those models and how they're impacting value-based care?
Yeah, absolutely. So there is the basic, fee-for-service chassis that we have in the Medicare program to start with. And let's put a pin in that because I will come back to that. Then in, fee-for-service Medicare, which is run by the government, partners with 99% of healthcare providers in the country, we have what's called accountable care organizations, where groups of providers can come together to say, I will take accountability for the cost and quality of care being provided to my patients. And so if you meet quality metrics, and if you save Medicare money, you share in the savings. So it's aligning the care and the incentives, if you will. And in the time that the Medicare Shared Savings Program, the largest such program, has been in operation, every year, providers in this program have knocked it out of the park on quality measures. They score higher in quality than healthcare providers not in the program. And they have saved the Medicare program billions of dollars every single year, because I think we all know that when you provide care in a smarter way, you keep people healthier and it doesn't cost as much because you're keeping them healthy, you're preventing ER visits, you're preventing hospitalizations, et cetera. Now, about half of the Medicare program is in Medicare Advantage, where Medicare partners with private plans to deliver Medicare benefits. Medicare Advantage, oftentimes they have more selective, provider networks. They can also provide additional supplemental benefits. And one of the areas that we really want to dig into is getting more data and transparency to understand how these benefits in Medicare Advantage, how relationships between the plans and providers in Medicare Advantage, what's working, what isn't, to further a dialogue, to further continuous learning for all of us. Coming back to what we were talking about before, I think that is the key, the data, being able to understand where you can provide care differently and what impact that has. And that's something that we all want to learn together. So we actually put out a request for comment in Medicare Advantage on data and transparency to be able to get ideas for how we can get more information on access to care, on innovations that are really driving whole person care, things that are improving the effectiveness of the healthcare program that we are collectively providing. So that's another call to action to everyone, that feel free to give us ideas.
I think one of the most important developments over the last decade has been this shift that we know clinicians like yourself are super important for the health of Medicare beneficiaries, but there's also this social determinants of health literature movement that's been so important in understanding that there's more than just clinical care that impacts the health of our Medicare beneficiaries. How central is that to what you're doing in your office, and why?
That is a perfect segue to where I said, let's put a pin in the fee-for-service chassis. But first, I'll give a story. So as I mentioned, I really do bring the stories of the people who I took care of to this role. So there was a woman who got readmitted to our ED in one of our Baltimore hospitals 17 times in a few months, 17 times. And we assigned a community health worker to her who went to her house. She had chronic obstructive pulmonary disease, went to her house, and it turned out that her electricity kept getting shut off, and so her nebulizer wasn't working. And so that's why she kept coming into the ER and then getting admitted to the hospital. So the community health worker, worked with the utility company to get that financial assistance so that her electricity wouldn't get shut off, and I think you all know what the outcome was, that she was able to stay healthy and in her house and did not have these constant visits to our hospitals anymore. I would say the other incredible part of this story is that that community health worker was part of a grant that we had with the state of Maryland where we did job training for people from the most underserved and lowest socioeconomic zip codes in the hospital catchment area. So it is a dual success story where you have someone from that local community who gets job training, is able to be employed, and then is able to give back to their community because, again, they know best in some ways of how to help their own neighbors. And so I think bringing that to the work that we're doing, we are trying to embed that in the very chassis of the Medicare program. So as I mentioned, things we're doing like creating payments for community health services, for care navigation. We're expanding the providers in behavioral health who can enroll in the Medicare program to include licensed marriage and family therapists, licensed mental health counselors, including addiction counselors. These are all ways that in the very foundation of the Medicare program, we are seeking to expand the way that we view care so that we really are able to address all the needs of people, and particularly in rural and underserved areas where not everyone has access to a psychiatrist, for example. And a lot of people have issues that are impacting their health that long precede any visit to a doctor's office.
I want to focus this in on the senior living sector. There are millions of individuals living in these communities around the country. In some ways, they can provide or form a framework for providing care on site. Nobody wants to go to the hospital, nobody wants to go to the ED, and it turns out not only do they not want to go, but it's not always good for their health. Individuals want care in place, but in the right place. Can senior living be a part of this vision you just outlined with value-based care, with holistic care, with social determinants of health? Is there an opportunity to provide services on site to avoid those costly ED visits and hospital transfers?
I absolutely think there is an opportunity to be able to provide care, bring care to where people are. And some of the, as you mentioned, Medicare is complex. So I'm going to try to explain the complexity of Medicare in 30 seconds or less. So Medicare at the 50,000-foot level is the Medicare statute or the Medicare law. That sets the overall framework of how we can operate the program. So we have to operate within the authorities granted to us in the Medicare law. So then you get to our regulations, which now all of you are going to read when they come out in the Federal Register, as David said you were going to. That is at the 25,000-foot level. Within what the authorities that the law provides, then we say, okay, this is how it can be implemented. But again, at that 25,000-foot level. Then you have how care plays out on the ground, where you have various healthcare providers, partners, patients, health plans who are actually engaged in the day-to-day care. And all three levels are really what comprise the full Medicare program. And I think it's important to mention that because sometimes it can be confusing for people to understand if a change is needed in the Medicare program, where does that change need to occur? So, for example, senior living is not an enrollable Medicare provider in the Medicare law. So I would not be able to say, oh, you in said senior living facility are doing a great job providing health care and keeping people out of the hospital, so now we're going to pay you directly. That is not possible in the Medicare law. However, this is where partnerships that, again, have to be data-driven to demonstrate quality, cost, because we have to be good stewards of our program, those partnerships can enable some of what everybody, all of us together, seek to provide. And that is where the power of these holistic care models, value-based care, really come into play, where we are saying to these providers who are accountable care organizations, you can take charge of your destiny and the destiny of your patients and really find new and innovative ways to keep people healthy, to save money, because that will benefit everybody and it will benefit you in the model that we have developed. So I think that is an example of how these partnerships can really come to life in the framework of the Medicare program.
Have you seen chronic disease management or other models being applied in the senior living space? Like, is that an example? I know there are examples of companies starting their own Medicare Advantage plans, and we could talk about that. There's a lot of developments in this space, but I'm curious what you might be seeing from your vantage point.
Well, I would say this is why we put out this request for information, especially on Medicare Advantage, because I think we need to have more data and more information. Because what does it mean to provide a benefit for healthcare in the home? Is it 3 visits a year? Or is it a more longitudinal approach? I think that there is a lot that we still need to learn about how these things can be provided and what impact they are having to really take that data-driven approach. And I think there's a huge opportunity for all of us to work together there. Because I will say, so when I took my role, I was on a panel with Mark McClellan, who some of you may know. He was CMS administrator a few administrations ago. And when he introduced me, he said, you know, this is Dr. Meena Seshamani. When her team and when her center puts out a regulation, they move more money than the GDP of several countries.
Wow.
Right? The Medicare program is almost $1 trillion a year. So we cannot take decisions lightly here, because we are talking about the health, safety, and well-being of some of our most vulnerable populations. And we are talking about billions and trillions of dollars potentially. So it is extremely important for us to be able to use data, transparency, encourage innovation towards our collective goals, encourage market competition to compete in the ways that we want. You know, that is all very central to our mission.
I want to stick on this topic of data. You mentioned quality, costs. Many of the providers in the room are beginning to collect data. Skilled nursing is obviously very far along on that path, but I would say senior living is still starting down this path. From your perspective, what is important for them to collect? What would you like to know in terms of quality metrics? We can assume spending, but quality metrics, what would sort of be your top list here?
Great. So I'll say in twofold. First, there are things that we have been collecting right now, and we are trying to make improvements to that. Again, coming back to what I bring from my prior experiences, when I was leading care transformation, we had a huge spreadsheet, like 8-point font, of the 500 quality metrics that we were being held accountable to, different payers, different programs, and I was seeing patients every Friday. On Thursday, when I would go through the EMR to prepare myself for my clinic day, right, reading through the patient's charts, I was not looking at what health insurance each of my patients had, what quality metrics I was going to be held accountable to each patient. I was looking to see, why is this person coming in to see me? What's going on with them? And if I, as a health insurance, health policy, health economics expert, is not diving into the 500 different measures, that is not what's going to drive change in our healthcare system. So we have created across CMS a universal foundation, a core set of quality metrics that we are moving all of our programs towards. And I think that is a good place to start. So we actually did a New England Journal of Medicine article that lists out those quality metrics. It is a small group because we want to start somewhere in a way that really drives change and momentum and doesn't lend people to become scattershot and debating about, well, is well-controlled diabetes, hemoglobin A1C less than 8 or hemoglobin A1C less than 9. Instead, let's talk about how do we take better care of a diabetic population. So some of those measures include depression screening and follow-up, screening for substance use disorder and follow-up, breast cancer screening, colonoscopy screening, blood pressure control, diabetes management. And we don't want to stop there. It also includes things about patient experience, et cetera. But part of being able to streamline is that when you take out the noise, it enables you to better see where the gaps and opportunities are as well. And I think this is another call to action. This group did not know that they were getting this much homework. But it is also a call to action where, as you are forging partnerships, as you are thinking about different ways to care for our communities, what are the things that we should be measuring? What are the things that you want to be held accountable to? So we have where we are starting, but that is not where we want to finish. And I think this is where we also partner very closely with the Innovation Center, which is the other center that I cannot believe I did not mention in the overall organization of CMS. The Center for Medicare and Medicaid Innovation. We work very closely with them where they can test new models, new metrics, and if something works, then we can scale it into the Medicare program. So I think there is a huge opportunity here to be able to first report on the things that we have put out, total cost of care, avoidable hospital admissions, et cetera, and help us to think about what the next round of metrics should be so that we can continue to engage in this continuous learning together.
I wanted to ask a couple of questions about Medicare Advantage. The first, I for years do a long-term care lecture for our Harvard Medical School students. I have a very bold bullet on one of the slides that says Medicare does not cover long-term care, and that's still largely true, but there is an asterisk today. There's now a supplemental benefit within Medicare Advantage that allows some coverage of long-term care. And beyond making me put an asterisk on my slide, what on the ground, more importantly, what's happening with that supplemental benefit? Are you seeing it used? Where? How, it's still early, but I'm curious if there's been much uptake so far.
That is a very good question that we need more data to be able to assess. So we actually have recently put out guidance to health plans to report to us in their encounter data what is happening with supplemental benefits so that we can better understand what the take-up is for these supplemental benefits. We also want to be able to understand at a more granular level, what is this benefit, right? Because to your point, some long-term care coverage, what does that mean? And it could vary by plan, and we want to get a better understanding of that. And we recently proposed in our recent round of regulations other things around supplemental benefits. For example, that if somebody has not used their supplemental benefit, they need to be reminded of it. And mid-year, plans have to reach out to their enrollees and say, hey, here are the benefits that are available to you. Here is how you use them. Because we have heard that it is not always easy for people to know what they have available or to be able to use it. And again, you can have something available, but if it's not being used, then what impact is it really having? We also are now requiring for SSBCI, which is Special Supplemental Benefits for the Chronically Ill, that we have, as part of the bid process that health plans do to contract with us, that if they're offering one of these supplemental benefits, they have to demonstrate how it improves the health of their enrollees. So again, we're finding common sense ways to bring more data to bear and to make sure that what is being offered is actually delivering to people in Medicare Advantage.
I can just add a huge +1. I think we would all really benefit from getting better insights into how this long-term care supplemental benefit is being used. At least the early data we've seen is it's still not being used too much, but it would be nice, as you said, to understand what it actually means from plan to plan. So one other question about Medicare Advantage, and when you talk to skilled nursing providers, one of their pain points is certainly dealing with MA plans around prior authorization, care denials. Are you seeing that from where you sit? And if so, are there ways to ensure that our beneficiaries are getting the care they need in the place they need it?
That's a great question, and guess what? It's going to lead to more homework for everyone now. 2 years ago, we put out a request for information on the Medicare Advantage program broadly. We said Medicare Advantage comprises, a large proportion of, the Medicare population. We want to make sure that it is driving towards our collective goals around advancing health equity, improving access to care, driving innovation for whole person care, being able to be good stewards, and ensure affordability and sustainability of the Medicare program. So it was a call to everyone, give us your ideas. We got more than 4,000 comments. And prior authorization is something that we heard about from every single sector. From patients who said this is confusing and it's preventing me from getting my care, from healthcare providers who commented on the burden that it created, the hoops that you have to jump through to try to take care of your patients, from health plans saying we need clearer rules of the road, and from academics and thought leaders. So we recently put into place some of the most significant changes to prior authorization in Medicare Advantage. So for example, if there is a coverage decision in traditional fee-for-service Medicare, that has to be followed by Medicare Advantage. They cannot do anything additional, period. If there is no coverage decision on the fee-for-service Medicare side, then there can be prior authorization on the health plan side, and it has to be well-established clinical guidelines, it has to be publicly available, it has to be reviewed on at least an annual basis by clinical leadership. It has to run for the duration of a patient's course of treatment so that healthcare providers aren't calling up saying, yes, my patient still has this condition, now I need to jump through the hoops again with prior authorization. If somebody changes health plans, that prior authorization follows them for 90 days to ensure continuity of care. And if there is going to be a denial, that denial can only be made on an individual basis by a healthcare provider with relevant clinical expertise. So these are some of the changes that we have made with prior authorization that went into effect January 1st, 2024. So here's where the homework comes in. Because we need to hear from all of you if there are still issues, because we want to make sure through our oversight that these new regulations are being followed. And we also want to hear from all of you where there are further opportunities.
Great. So this is my last question, and then I'm going to turn it to Bob for audience questions, and Bob's collecting those. And I wanted to come back to the point of data. As a researcher, I love data, collect all the measures, all the 500. I want to see all. I'm half kidding there, but more is better. From a provider perspective, however, there's a cost with collecting and reporting these measures, and we heard this a lot during the pandemic with the National Healthcare Safety Network and nursing homes and just the additional data burden. Is this something that you're monitoring in your office, and what are you seeing, and how do we kind of find that sweet spot where we are collecting the measures that matter but not overburdening providers?
I think you hit the nail on the head, David, about finding that sweet spot. As a health economist, health services researcher, physician, you can't improve what you're not measuring, right? And also, people need to have the opportunity to be able to choose and to be able to pick that option that works best for them, which also requires information. So we need to make sure that we are collecting data, that we are measuring, and that we're doing it in a way that is efficient and streamlined and is actionable. So to come back to this universal foundation, I think that's a good example where we are trying to really streamline the data collection so that we can make sure that we are really driving the kinds of change that we all want while not creating undue, unnecessary burden. I think this is also where the recent request for comment that we put out on data in Medicare Advantage, which now, by what you said, I expect to get comments from you, David. But that is also where we want to hear from everyone about what could be useful, because we want to hear from all of you what is useful, what would be unnecessary burden that doesn't get us to where we need to go. So I think that is something that is definitely, front of mind for us. And I think as all of you know, it's been a theme of what we've been talking about in this session. We do need to have data, because otherwise, how are we going to know where the gaps are, where the good work is happening, and where we can further improve things?
Well, I like that I didn't escape the homework assignment.
Yes, exactly.
So we're all in this together. So Bob, do you have some audience questions? That
I do indeed. We're getting a number of questions in, not surprising. That's great, thank you. One, picking up on your comments, kind of talking, Dr. Seshamani, about the different parts of CMS and then your different programs. The question has come in, what currently achieves a lower cost of care? Medicare, meaning fee-for-service traditional, or Medicare Advantage?
So that is a very good question. I will say that some of this comes back to where we want to get more data on the Medicare Advantage side. If you just look at the cost, Medicare Advantage per enrollee costs more than Medicare fee-for-service, but as we all know, there is a lot more to healthcare than just one number. Another thing that I mentioned, our accountable care organizations absolutely are saving money and delivering better care. Year on year, the program has higher quality measures and has saved several $1 billion to the Medicare program. So I think that is a prime example of where, when we all work together, we can really provide better care and improve health outcomes while spending money in a smarter way.
Great. If you want to submit questions, let me just tell you, we're getting a number, but feel free to submit. It's the top link on the homepage. So please, on the app, that is. Another question that's come in is behind the scenes. And I don't know how much you can share behind the scenes, but the questioner says, is there an active strategy to mitigate staffing shortages, the nursing crisis, et cetera? Are the labor challenges part of the conversation? What can you share with us?
Yeah, I mean, I will say overall, I think we are all acutely aware of workforce shortages. And this is where I think, again, there are real partnerships where we can get those win-wins. So I'll come back to the example I gave with the community health worker, where now, if Medicare is paying for the services that community health worker provides, that creates an opportunity for hiring, which then can mean, okay, then workforce training programs can train people who can then get hired. When I was traveling in Florida, I met with members of the Florida Behavioral Health Association. One of the things that we talked about was peer recovery workers. So again, Medicare for the first time is paying for care navigation, and that's something that peer recovery workers can do for people with substance use disorder. And we talked about how people who are in recovery, enabling them to be employed when they finish with rehabilitation is hugely important to their success. And what an opportunity it is if now their services can be paid for by Medicare for recovery programs to have workforce training as part of their recovery program, so then people can then be employed. And thinking about those win-wins that extend beyond just the Medicare regulation. That's why traveling, meeting with people, generating these ideas is so important, because to come back to the 3 levels I mentioned of Medicare, this is where things come to life on the ground, where my team and I, in our regulations, can make that opportunity available, but then all of you need to capitalize on that opportunity.
Thanks. Another question that's come in is, there's been much discussion since the reintroduction of the 3-day stay rule after the period it was suspended during COVID. What does this rule mean for MA plans or others who are holding healthcare dollar risk for older adults?
Thank you for that question. I will say that that is probably a pretty technical question. We do have some FAQs, et cetera, and we can definitely follow up with whoever wants to dive in more.
But you have been issuing some things with regard to explaining to MA plans,
yes,
how they must address that issue.
Yes.
It's not a we're not dealing with it.
Oh no, we never say in Medicare we're not dealing with it. We are constantly dealing with things.
Okay.
And
right.
I mean, this is also where this engagement is really important, where we are constantly saying to people, if there are areas that need clarification, please let us know so that we can work through things. Because healthcare is ever changing. You can't always, what the situation is today may not be the situation tomorrow. And that is something that I think we are all very aware of.
Bob, if I could also just jump in on the 3-day rule. There's also this source of confusion with observation stays and how those count towards the 2 midnight or 3-day rule. And so I do think there's a lot of interest from a policy perspective in figuring out kind of, because I think our beneficiaries are confused. I just had a colleague whose mom was at an ob stay and thought she had the 3 days and didn't. And so it is a confusing rule for beneficiaries.
Without question. And surprising. In other words, they're surprised by what they learn. So another question, again, not necessarily something that you control, Dr. Seshamani, but with projected Medicare Part A trust fund solvency issues projected within the next few years, how should operators and investors be preparing for potential changes to benefit structure?
That's a great question. I would say we need to be thinking about that now, and it really comes back to the conversation that we've been having here. How do we spend the Medicare dollar in a smart way to keep people healthy, to provide better care? How do we get the data we need to see what works and what doesn't? Because that is part of responsible stewardship of our program, and that is a collective responsibility for all of us. So I would say proactively, what we've been talking about here today is central to the question of continuing Medicare trust fund solvency, and where we want to make sure that we are paying accurately. We want to make sure that we have transparency and competition and a market that is functioning to support that. And we want to make sure that we're doing it together. Great.
Well, now that I made that announcement, I've been deluged with questions, so I know we won't get through all of them, but you've definitely got folks' ear. Palliative care can save CMS money through goals of care, conversation, symptom management. Is CMS considering increasing reimbursement levels for palliative care providers?
That is a great question. Some of that comes back to what we were talking about with the 3 levels of how Medicare works. Quite a bit of the rate setting that occurs in the physician fee schedule is set by Medicare law. There are quite a few mathematical requirements that we have to follow. And there are areas within that where we have some administrative authorities or flexibilities. So for example, we created a new code, G2211, that provides additional payment for complex and longitudinal care. That is something we wanted to be able to recognize, that really understanding people as people, establishing those long-term relationships, addressing issues beyond a 15-minute, office visit is important for keeping people healthy. So we created an add-on payment that can be utilized for service lines, specialties that are engaged in that kind of complex longitudinal care. So that is an example of how the physician fee schedule works and how we are leveraging our administrative authorities to try to, move reimbursement where care is needed.
Great. Another question that's come in, can you share any examples of what providers or plans are doing the best or innovative work to meet your goals? In other words, what are exciting things you're seeing towards your goals in terms of innovation at the level of what plans and providers are doing?
Yeah, well, I'll give one. That's a great question. I'll give one example. I mentioned to you that we are partnering very closely with the Center for Medicare and Medicaid Innovation, the Innovation Center, where if they test something and it works, we want to be able to scale it, writ large in the Medicare program. One example was that the Innovation Center tested a model where for smaller providers in rural and underserved areas, if you give them upfront investment dollars and they invest that money into their practice, into taking better care of their communities, guess what? They achieve higher quality and they end up saving money for the Medicare program because they're keeping their communities healthy and keeping them out of the hospital, for example. So we took that idea and we scaled it into the Medicare program. It's called the Advanced Investment Payments Program. This is the first year that we're rolling it out. And so we have about 20 provider organizations in smaller providers in rural and underserved areas who are getting upfront money from us to be able to invest in their practices. They are investing in community health as a key area. They are investing in staff such as nurses and social workers and psychologists. So I think on the ground, that is a real-time example of where when you can provide that support, then people are innovating in ways that we know is going to be a good investment because then they are going to keep their communities healthy, which ultimately is a win-win because you're keeping the communities healthy and you're avoiding unnecessary expenditures.
Great. Here's a question that's come in. Each year it seems there are fewer new doctors choosing geriatrics, while at the same time a bigger percentage of their patient population are older adults. How can we change that trend?
Another great question. So the Medicare program also runs graduate medical education. Coming back to the 3 layers of Medicare, graduate medical education has a lot that is required by Medicare law, the Medicare statute. Thanks to congressional action, we were given the incredible opportunity to roll out 1,000 new training slots, 200 a year over 5 years. And we, in our regulations, made the decision to prioritize those slots to rural and underserved areas. And the first round of slots that went out, the majority went for primary care, behavioral health, and that includes geriatrics. So, that is an example of where we are taking a Medicare lever, to try to apply. The other thing that I will say is, coming back to the example I gave with G2211, where we are looking for ways that we can further support primary care, behavioral health, longitudinal care in our fee schedule and reimbursement.
Another question that's come in is, CMS has reduced some of the barriers to care due to prior authorization, but MA plans also deny care by limiting length of stay. Will CMS prevent or take any other steps with regard to MA plans doing this?
That's a great question, and again, this is where we want to continue the dialogue and see, where there are other opportunities. I will say that, some of the things that we have put in place, like denials, of care can only be by a provider with relevant clinical expertise. There are some things that we have put in place that we want everybody's eyes and ears to make sure that they are being followed.
Okay. Here's a broad question, but again, very specific to the seniors housing and care sector. Recognizing the seniors housing and care offers various non-medical services that can improve health. How is CMS thinking that seniors housing and care providers can partner with MA plans to support the goal of transitioning seniors housing to value-based care?
That's another great question. I would raise this up a level, that it is not just about partnering with Medicare Advantage, it's about partnering with healthcare providers, right, writ large, where in the fee-for-service Medicare, where we have these accountable care organizations, there are opportunities to partner with these providers to demonstrate, hey, here is a way that you can provide better care to your communities, keep them healthy, you'll improve your quality metrics, and you will save money, and the provider shares in those savings. On the Medicare Advantage side, this is where we want to get more information on what kinds of benefits, what kinds of work is working and how. So I think this is a huge opportunity for us to engage, to get more data and transparency in analytics.
There's a question about the GUIDE program, which I don't believe falls into your area, but I don't know, it may be just telling folks where they can get this. It says, tell me about GUIDE, and does that apply to senior living?
So the GUIDE program is an innovation center model. So this is a very good example of where the innovation center tests things, and then they're like the R&D arm for Medicare and Medicaid. And then we can see in the Medicare program, is this something that works? Are there concepts here that works? And are there ways that if they work, that they can be incorporated into the Medicare program? So that is one example.
Coming back, a number of questions related to MA plans. How does CMS hold a Medicare Advantage accountable to follow the new rules imposed with regards to pre-authorization transfers from one provider to another?
I'm so glad that you asked that question, and I apologize, I should have said that at the outset. We do have an oversight and auditing structure in our center to be able to audit plans to see if they are following our regulations. We do that on a regular basis, and we are making a targeted effort for the new policies that we have put into place. And we also look at complaints and concerns that come in to also help guide us for where we need to do oversight and auditing. So that is why it is very important to us that we hear from people if there are issues, so that we can, both through our regular ongoing, and then are there areas that we need to focus on?
Yeah. Here's a really good follow-up question to the discussion that we've been having. Where do we send our feedback on your calls to action today, like data metrics of interest?
So data metrics of interest, we have a request for comment right now that is out on Medicare Advantage. I think the comment period closes May 29th. So there is time, but we all know that that time will slip through our fingers. If I figure out how to make the Earth rotate slower, I'll let all of you know. So there is that opportunity. There are also ongoing opportunities both through all of the regulations we put out. We have notice and comment rulemaking. So anytime we put out a regulation, it is proposed, and we take in comment to incorporate when we finalize. So that is another good way to provide feedback. And a third way is that we regularly host listening sessions, meetings, to be able to hear from people. And so I think that is a third, good avenue, which is why it's really good to have sessions like this, right? To get you all thinking, and then, we are happy to organize, a follow-up meeting, for example, where we can get some ideas back to consider.
I want to close because I know we're getting close to our time here, and we've got so many great questions that have come in. And thank you for stimulating this dialogue with your comments, Dr. Seshamani. But There's a question here that's a little bit contrarian to the very direction that you've been taking Medicare with regard to the movement by 2030 to getting all beneficiaries in some value-based care arrangement. It says, Medicare Advantage seems to be best applied when skilled care isn't part of the patient's scenario. Vision, dental benefits are great. Can you imagine, though, a solution that moves a patient to fee-for-service? In other words, I think it's probably, if I can interpret, and I may be doing this wrongly, someone has chosen, because of the vision and dental and eye benefits, has chosen to move into an MA plan. But then they decide, well, that was great, but now they're going to move back to fee-for-service because they think the benefits they're going to get in terms of skilled care and rehab and so forth, they're going to get more days and they're going to get more care because of what they're hearing from their friends about pre-authorizations, denials, shorter lengths of stay, and so forth. So I think that's what's behind the question.
Yeah, and you know, that is a great question, and I think an area that we are really focused on is how do we enable people to choose what works best for them? So we are working very closely with our communications team. We're constantly looking to improve Medicare.gov and Plan Finder so that we can provide the information that people need to understand the choices that they're making. And this comes to the second part of, you know, if you're to switch from MA to fee-for-service, Medigap policies vary by state. And there are some states where there is not guaranteed issue in Medigap. So what that means is, if you're in one of these states, and we have that information on, you know, Medicare.gov, if you're in Medicare Advantage and then you want to switch back to fee-for-service, it may be hard for you to get supplemental coverage, a Medigap policy. This is something that we have definitely heard is an area of confusion for people. And we are really trying to make that clearer through all of our engagement so that people know what choices they are making when they are making choices, particularly between MA and fee-for-service. And I think this is another area where we would want to continue to hear from all of you, and we're doing focus groups with seniors so that we can continue to improve our outreach. Each open enrollment that we do, we are improving our messaging so that people can better understand what options they have available. Sorry. And, you know, also, this is where we have taken a lot of efforts to crack down on misleading marketing as well. In the last open enrollment, we rejected more than 1,000 TV ads that were found to be misleading for people in Medicare, because we want to make sure that people can choose what is best for their health and financial needs.
Well, thank you. We could go on and on. We had so many great questions that came in, but I hope one of the things that's really clear is Dr. Seshamani is here because she wants a dialogue. In addition, she believes that that dialogue is going to help her and help her team, and that achieving the goal that we all have of better health for our residents and a system that more works for them rather than seems to be just a constant source of frustration, both for their care provider as well as for the individual and their family. And I think another note that hopefully all of us heard is the importance of data. We have an enormous opportunity as a sector because we have our eyes 24/7 basically on Medicare beneficiaries. And we have our eyes 24/7 on the folks that are the 51% that are now in MA plans and the many that are in ACO REACH plans. So we have an opportunity to be collecting data, because I think there's one, if I had to underline one thing about our interaction as a sector, now that we, so to speak, have moved from side stage to main stage in terms of the nation's health, particularly as it regards the healthcare costs and the quality of life for older adults, it's that we've got to provide data. We just can't say we do a great job. We make such a difference. Senior living is wonderful. It's about the data. And Dr. Seshamani's appearance here, and she has basically opened the door and said, okay, give us your data. Show us your results. So thank you again. Thank you, David, for leading this fireside chat. Sorry there was no fire.
Maybe that's a good thing.
Yeah, Dr. Seshamani, thank you so much for making the trip, and thank you for your candor in the discussion and your responses, but also your passion and your energy that really comes across. And we're so grateful to you and for this opportunity to have this dialogue. So thanks very much.